This is chronic bronchitis, and this is emphysema. Some COAD patients are breathless, but they are not cyanosed. When we call these patients the pink puffers, and they are the patients having emphysema. And some are cyanotic, bluish discoloration of the skin. And if heart failure, which usually complicates these patients, they become edematous or bloated, and they are called blue bloaters. And these are usually the patients having chronic bronchitis. In these patients, the respiratory centers are relatively insensitive to carbon dioxide, and they rely on the hypoxic drive to maintain respiratory effort. That's why it's dangerous to give high levels of oxygen for more than brief periods to these patients, as breathing may stop. The blue bloater is the patient having chronic bronchitis, while the pink puffer is the patient with emphysema. So what's the management of chronic obstructive airway disease, whether chronic bronchitis or emphysema? Dental treatment is avoided during an exacerbation of COAD. Dental treatment should be carried out under local anesthesia, and if general anesthesia is unavoidable, then the condition of the patient should be first optimized using preoperative physiotherapy, antibiotics, bronchodilators, etc. Patients may become dyspneic, especially when supine, and if a rubber dam is necessary, then oxygen via nasal cannula may be required, but in low concentrations. Never give high levels of oxygen for more than brief periods to these patients, as breathing may stop. And this is because the respiratory centers in these patients are sensitive to carbon dioxide and rely on the hypoxic drive to maintain respiration. So if a rubber dam is necessary, then oxygen via a nasal cannula, like this picture, should be used, but in low concentration. Tuberculosis or TB. It's caused by Mycobacterium tuberculosis, and this occurs in immunocompromised HIV and in the malnourished patients, and also with patients or individuals which use this type of smoking. Primary infections are subclinical. It's highly infectious when active, and the infection is through inhaling the infected sputum. Risk to dental staff is rare unless active pulmonary TB, where elective dental treatment should be deferred until the completion of a full course of anti-tuberculous treatment. And in emergency treatment, we have to reduce aerosols, use rubber dam, wear masks, spectacles, good ventilation. That is to minimize the risk of spread of infection. Bronchial asthma. There is a very close relation between stress and the precipitation of an attack of bronchial asthma. So our first role is to calm anxiety of the patients, as anxiety and stress may induce a bronchial asthma attack. We are justified to defer treatment if the patients came to the clinic without bringing their medications along. Nitrous oxide analgesia is the best because of the rapid control. Once you remove the mask of the nitrous oxide, the patient wakes up. Aspirin-like and sulfite-containing compounds, and even many of the non-steroidal anti-inflammatory drugs should not be prescribed, as they are or they can induce attack of bronchial asthma. Treatment of bronchial asthma attack in the dental clinic. Number one is the salbutamol inhaler or nebulizer, and usually this is the medication that the patient brings with him to the dental clinic. Number two, epinephrine in severe cases, and this is only in children, and the dose is the same as in anaphylactic shocks, that is 0.5 milliliters intramuscular in a concentration of 1 to 1000. Third line of treatment is hydrocortisone, intravenously 200 to 500 milligrams, and the fourth line of treatment is aminophylline intravenously if no response to nebulizer, but this line should be delayed better until medical assistance is available, as aminophylline is arrhythmogenic. Patients taking steroids. Patients taking steroids may require steroid supplementation before dental treatment. In invasive procedures such as third molar surgery, very apprehensive patients, or the patients taking corticosteroids in a low dose, less than 20 milligrams prednisolone, or have done so in the last month, or even patients who took steroids in the last year for more than 1 month. And number 5, Addison's disease. If the supplementary dose of corticosteroid is not given before the dental treatment, then at least monitor the blood pressure. If the diastolic pressure falls more than 25%, give intravenous hydrocortisone 100 milligram at once. Pictures of cyanosis. Cyanosis can be central, seen in the lips and the tongue, or can be peripheral, seen in the fingers. Thank you very much.